Continuing our healing discussion, the next tissue that we look at is the cartilage. There are 3 major types of cartilages that we have in our body: hyaline cartilage, fibro cartilage, and elastic cartilage. But mainly what we're going to be talking about here is the articular cartilage, so the cartilage that you can find over the articular surface where 2 bones or 2 or more bones would meet. So that in that setting, the type of the cartilage that we see is the hyaline cartilage specifically. Okay, so that's the main thing that we're going to be talking about. Looking at the cartilage structure, look at the fibers, the orientation of the fibers. But depending on the layer, it has a very different orientation. Superficial layer, those fibers are laid in more of a parallel or horizontal fashion compared to deep layer, which you have more of a vertical structure. Okay, so think about what kind of a force they might be better at resisting against. For example, the superficial layer is going to be awesome resisting against the shear force. Compared to the deeper layer, they're going to be awesome at resisting against the compressive force. Okay, so depending on the damage of the cartilage, if patient ever comes in with the articular cartilage tear, I need to identify what layer is being affected. I would like to, so I can start to form some rehab. For example, if the patient is experiencing a superficial layer cartilage damage, I would try to avoid the shear force, shear loading of the cartilage, because that might make the pain worse, and maybe start to focus on more of a compressional force, and vice versa. Okay, so you need to know a little bit about the tissue. Cartilage tear is classified into partial versus full thickness tear. So here's a good picture of the scope. So what you see is 2 articular surfaces meeting, and these cartilage looking nice and smooth. It's perfectly healthy. Compared to this, okay, this is an example of the partial thickness tear. So what you see is a nice tear at the cartilage. Okay, but it's not going all the way, it's just maybe into a half layer, middle layer, partial tear. If the tear is going to go all the way, and what you see here is the bone underneath the cartilage being exposed, okay, that's a full thickness tear. So the tear is happening all the way, and now the subchondral layer, which is bone, is being exposed. Now, the problem with the cartilage cell is the healing is going to be very limited because the tissue is very avascular, meaning that, there's no blood coming in, no nutrient coming in. It has a very, very limited ability to heal. If you are super lucky and start to have some chondroblast activity going on, then maybe it might take 2 weeks for the chondrocyte to lay around an area, and 2, maybe more months for the collagen fibers to come in and start to form, fill in the gap. So compared to bone healing, it's going to take significantly longer time, and then still healing might be very, very limited. Key to success for cartilage healing is the joint motion, because we can't really rely on the blood supply, unfortunately. So what we're going to have to rely on is the synovial fluid. Okay, so where we have these 2 bones meeting, okay, you have synovial joint capsule, and within that capsule you have synovial fluid. Okay, so between those 2 bones you have a lot of synovial fluid, which you have a good amount of nutrients within. Okay, so how can we facilitate the cartilage's uptake of those nutrients? Well, again, the cartilage itself cannot reach out and then grab those nutrients. The nutrient will have to move for them and come at them. Okay, very important thing is that joint that we just experienced the damage, we have to keep it moving so we can move the synovial fluid, and synovial fluid is going to come in contact with the damaged site, and it's going to start to facilitate the healing. So motion is the key. Another thing is the alternating periods of loading and unloading. We don't just move it, okay? We have to start to load the structure, but also that loading phase must accompany with the complete unloading phase right after that, and then they have to go back and forth. So for example, if this is a knee joint, okay? Worst thing you can do for your knee joint is you just stand on that leg, you just load and don't move. So you continue to load. Okay, what's going to happen is you apply some nice compressive force over the cartilage. It's going to squeeze the fluid out of it. Okay, and when you lose the fluid content from the cartilage, it's going to be more vulnerable for damage. So that's the worst you can do for your joint, loading it and then just not letting it go. What you want to see is the, again, alternating period of loading and unloading. So the great activity that they can do is something like maybe this: marching, walking. They can repeat the period of loading and unloading by shifting weight back and forth. Okay, and they need to move their knee throughout the available range of motion. Okay, to hit both. Loading and unloading and moving for cartilage is like breathing. Okay, so every time you load and unload and you move that joint, those cartilages are breathing and they're getting nutrient, so it's going to facilitate the healing. So if my patient, maybe with this cartilage tear or a knee OA or something like that, complaining a lot about pain, suggestion that I would make is, well, let's go ahead and move. Let's go ahead and move. And if that loading as of right now is very painful because it's very inflamed at this point, we can do it in water. There are a couple different surgical procedures that a patient might go through to deal with the bone damage or cartilage damage. Interesting one is this procedure known as osteotomy, which basically means cutting the bone. This procedure is often used to correct the alignment issue. So for example, this patient's knee alignment, maybe you might identify significant knee varus formation. And maybe you tried everything you could and then just not going anywhere, and then you decided that, okay, it's just coming from the bone, so we're going to correct it through surgery. What people might do is the procedure known as closing wedge osteotomy, meaning that they're going to cut this particular part of the bone and shift this bone back up so you would have a little better alignment of the knee. This is much more of a natural angle. Or if you need to create more angle, maybe your patient have an opposite deformity, knee valgus, it collapses in. What you might have to do is to have this opening wedge osteotomy. So you're going to cut this bone right in here and you're going to create more angle, creating this gap, okay, and stabilize it there. And again, your bone has a very excellent ability to come in and heal, right? So it might take some time, yes, but it's going to reconnect, and now you have better alignment of the knee. Fusion is also a possibility, more for older population. Definitely we see more procedure on a spinal segment, maybe cervical or lumbar spine segment. So you actually use a piece of maybe metal to completely fuse these two bones together. So what you're going to have to be aware of is this patient's now experiencing the major mechanical change. Those segment is not supposed to be moving anymore. So if you think that, your cervical spine, the lumbar spine is not really moving as it should, and I'm going to force it to move by performing a joint mob, that's probably not going to be a great idea. You have to understand that the mechanics of that joint is completely now has changed. Debridement is a very common option for cartilage damage, and what you're looking at here in the slide is a meniscal tear of the knee, because the meniscus is also a piece of cartilage. So what you see is a nice tear, and then the edge of the tear is really uneven and really jaggy. So what could happen if you don't do anything for the tear is maybe during the knee motion, this little flapping portion might get caught, and the tear might become worse. Okay, so what you might want to do is to perform the debridement surgery to provide some temporary relief, and then maybe we can try to contain the damage. So we can come in and reshape this bone. Okay, so you're gonna have a nice smooth surface, much less risk of this tear getting caught in the motion and then make the tear worse. Now this is not really facilitating any healing. We're trying to contain the damage. So the improvement the patient might feel is very short-lived. After surgery, they might go, oh yeah, there's no more catch and lock and it feels better. But long-term, they still might experience a degeneration of the meniscus, a degeneration of the joint itself. That's still a possibility because we didn't really address the issue. Microfracture procedure is a very interesting procedure. So this procedure is performed for a little bigger cartilage tear, and maybe it's in a very portion that they need some cartilage in there. It's a nice important cushion that that we all need to have. So what you're looking at here with this scope video is a full thickness cartilage tear, as you can see. So the layer that we're looking at here is all bone. Okay, cartilage is gone. So the microfracture procedure, what they're going to do is the surgeon is going to come in and drill very teeny tiny holes, but a lot of them over the bone surface. Okay, Like we mentioned a little bit ago, bone, you have a nice blood supply. So we're going to facilitate the bleeding from the bone tissue, which is going to come in, fill in the gap, and then now, using that blood, using that nutrient, we can recreate the cartilage, which sounds awesome. A little problem with this procedure, you cannot load the surface for a very long time. You really have to let it bleed, and fibroblasts, everything need to come in and start to lay some layer of the cartilage, which takes some time, unfortunately. Okay, so you cannot load this one for a very long period of time, and the type of the cartilage that you're gonna get at the end is the fibrocartilage. It's not that original tissue, which is the hyaline cartilage. So yeah, this is going to help you forming the cartilage, but it's just not going to be as good as the original tissue, unfortunately. Okay, but the idea is it's still better than nothing, and then you still got some healing going on. If I can skip this video and then get to this next phase, what you start to see is the bleeding, the blood coming from these holes. Okay, and this is what we want, so this is great. So you start to see some blood coming from the bone because you have a lot of blood supply, and that blood is going to come in, start to fill in the gap, and then now you start to experience some regeneration. Again, not the best type of the cartilage, not the ideal, but still better than nothing. Some other procedures, osteochondral auto or allograft transplantation. So we're going to take a cartilage cell from somewhere else, okay, and try to use that to replace the damaged cartilage. And sometimes you use your own cell, which is an autograft, or maybe use a cadaver cell, autograft. And for this particular procedure, you might go, well, then you are kind of taking your own tissue here. How does that make sense? Well, you have to look at the area of the damage. Okay, this is more of a weight-bearing portion, meaning that when you're standing on your leg, this portion is going to be loaded. You need cushion here. Compared to here, you don't really load it. So it's okay for you to have a little bit of loss of the tissue compared to here. Okay, so sometimes they can cut the little piece of the cartilage and then try to plug it in. The next and maybe most technologically enhanced procedure is this chondrocyte implantation. So what you're going to do is you're going to take a little sample of yourself, of the cartilage cell, and you're going to cultivate it for a specific period of time. And this particular damaged area you have, it's just like a debridement. You're going to come in and shave it up, okay? And you're going to put this chondrocytes, which you cultivated, put it back to fill in the gap and stitch it up and letting it heal. And then here's the actual patient who just experienced this procedure. You can see the plug that they created, okay, is not filling the gap, and hopefully you can just let it heal. This procedure, I don't know too much about the actual cost, but you have to have at least 2 surgeries, one here and one there. So I would imagine that the cost of this technique is going to go a little bit higher compared to other procedures, and it's going to take a little bit more of a time. But success rate so far, as far as we see in the literature, is much better compared to some other techniques. The last one we have is the nerve healing. Central nervous system, your brain and your spinal cord, you have very limited ability to regenerate. So unfortunately, if you are to damage the spinal cord, you may not be able to regenerate or go through the healing. But again, I think I mentioned that a little bit ago in class in this semester, but the brain is plastic. So if you experience the blood, brain cell damage, like from a stroke, those cells that you lost, you cannot regenerate. But what brain is capable of doing is they can reassign the functions with the cells that we have still available. And we're going to talk about this concept, neuroplasticity, later in the semester, so wait for that. PNS, peripheral nervous system. So the actual nerves that you can find in your arms and legs, they have ability to regenerate. It's limited and it's actually slow, only 3 or 4 millimeters per day, but it certainly do have ability to regenerate. But under certain conditions. So for example, if you're looking at a nerve here, here's the nerve cell body and axon and innervating the muscle tissue, and then here you have a damage. As long as the damage is away from the cell body, okay, what you might experience initially is maybe this nerve that got cut, you might lose it. But as long as the cell body is doing okay, it has ability to regenerate and then reconnect with the muscle. Okay, so that's one ability. If the cell body is being affected, then maybe you may not be able to regenerate that nerve. specific procedure you can perform to facilitate the healing is a surgical repair. So this is a sciatic nerve that got cut in the middle. You can actually surgically reattach that nerve, try to facilitate that little higher regeneration rate for the nerve. So that is all I have for the healing process, and we're gonna start to talk about the next chapter.